You're listening to the Medic Materials Podcast, hosted by Mike Turek, a paramedic and educator with over 10 years' experience. Every month we review actual EMS calls with the help of current practicing EMS providers, bringing educational opportunities directly to the listener. Portions of the calls have been altered to protect the privacy and identity of those involved.
Hello and welcome everybody to the Medic Materials Podcast. It is a special day today, being that it's November 15th, and typically we only do podcasts on the first of the month. But we as a group, Gerard, you're sitting here today. Emily, You're sitting here today as the podcast regulars. We're also joined with Kelsey, the resident EMT intern, who sooner or later
is always going to be her name. Like,
I think
she'll be like a PA, and she'll be like, "Hey, we still have Kelsey, the intern, with us."
I think so.
Okay.
I'm pretty sure that is your name from now on. So, being that it's the 15th, I thought, looking at all of the numbers on, the analytic pages for the podcast and for the YouTube channel, and specifically the videos of the podcast on the YouTube channel, it's clear that you guys enjoy what we're talking about. So I was looking on YouTube literally this morning, and there was over 3,000, almost 4,000 minutes of watch time just for the podcast. And I think that's awesome. So you guys, Gerard, you were talking to somebody who was like, yeah, I listen all the time.
Yeah, texted me out of the blue and was like, dude, awesome job. I'm like, all right, cool.
Yeah, and that's been news to me.
Right.
So we've been putting these out there as kind of a fun discussion that we have once or twice a month. And here it's already growing 4 episodes in. So hopefully you guys enjoy. We're going to get down and dirty in a call review shortly, but the way this new format is going to work is the first of the month is either going to be a call review or just a generalized open discussion. And then the 15th of every month is going to be the reverse of that. So if we did the discussion first, we'll do the call review that ties both together. This month, we already had our discussion in that when to pull the trigger or when to sit on your hands. Now we're going to talk about a call where that exact choice needed to be made. So let me paint the picture for you guys. You have a residential, very, I would say, non-urban, so rural is the word I'm looking for, environment. You're going to a maximum security prison for a 68-year-old male, lethargic and unresponsive. You have a medic in a fly car, and you have a BLS ambulance transporting system that you're responding with. You, of course, have the guards. The patient is in the infirmary. Anything you're thinking about first off, just with where this patient's located?
Time to access the patient. How long is it going to take to get into him? Because there is most definitely not a open door policy at a maximum security prison.
No, and typically this, talking to the provider, typically this prison takes upwards of 10 or 15 minutes just to clear the gate, clear front security. They have to go through all of your stuff. You're not allowed to bring in certain, like you're not allowed to bring in shears and stuff like that. Pretty much your cardiac monitor, your airway stuff, and your drug bag. It's pretty much all you're allowed. And then, of course, the infirmary is on the other side of the building. So you have a good 15 minutes before you can access the patient before anything. So when you finally do get to the infirmary, you meet the nurse, and the nurse goes, yep, so this is this gentleman. He came to me about a half an hour ago. He's been very lethargic. His eyes are open, but he's completely unresponsive to us. Okay, so with that, what do you guys want to know? I'm going to talk to Kelsey first. Try and get her OPQRST ABCs thing going here. What are you thinking? What do you want to do first on this guy?
So I guess one of the first things I'm thinking is, when did it start? And basically what happened, because I don't really know pretty much anything about prisons, but I've read a couple cool books about like doctors in the infirmary, and there's a lot of times that some of the, I'm like generalizing here, that some of the doctors you can't give patients certain things, because then basically the patients will use you and they'll lie to you about it because you can sell drugs or pillows or whatever in a prison system. So I guess I
can honestly say I've never heard of pillows being
pillows,
used as
but
currency.
I like it.
I mean,
I have heard of clean socks.
No,
I mean,
serious.
clean socks, yes, but
I would kill for a clean pillow, so I'm all on board.
I read this book called Maximum Security Prison, and it was about this doctor who got a job at a maximum security prison, and he would have patients that would tell them that their backs hurt to get a new mattress, because apparently having a new mattress meant something in the prison.
Shot caller.
yeah, seriously. I mean, who's to say they're not clever, right? I mean, bravo, good for them.
From the people who brought you Pruno.
So I guess that's what in the back of my mind I'm thinking is, what did he actually tell them versus what's going on? Because especially in a prison, that could greatly differ.
All right, so this is where it gets interesting. So he was in his cell, okay?
Wasn't shivved.
Wasn't shivved.
Okay.
There is zero trauma. Zero trauma. Wasn't shanked, wasn't shivved, didn't get butt raped by a large inmate. Nothing in there. Sitting in his cell. The guards walked by him on their morning rounds. Completely fine. Walked by him in the afternoon rounds. Again, completely fine. Answered, hey, how you doing? Blah, blah, blah. What's going on? Third time in the evening rounds after dinner, they walked by and found him like this, unresponsive in this lethargic state, eyes open, non-responsive, sitting. Didn't look like there was any trauma. They didn't believe that there was any foul play. He'd been alone all day. Didn't think that he had ingested something, like nothing like that. So they were like, okay, this is weird. Let's bring him over to the infirmary. This specific prison system does not have doctors present. They have doctors on call. They have nursing staff that's, registered nurses there. So this nurse called the doc. The doc was like, yep, nope, send him out. So that's how EMS initially got called. The only thing that he responded to EMS with was the word yup. And if I can do my impression the best as to how this paramedic told me this story, was this guy, no matter what you asked him, no matter when you asked him, from start to finish of the call, he went, yup. And that was it. That was the only response you ever got from this guy. Now what?
Yep.
Yep. I'm sure that the first 8 times this guy goes, yep. The paramedic's like, fuck.
So we've ruled out incarceritis, or have we?
So typically, according to...
What is incarceritis?
I don't want to be
Gerard,
here. My chest hurts. Please take me to the
Oh,
hospital.
got it.
It's an inflammation of every body system because you don't want to be incarcerated anymore.
Typically, at least in my own seeing of incarceritis, I see it more in people getting arrested, not the ones that have
are
been
already there.
arrested.
Exactly.
Right.
Like this,
Everybody needs a day off.
everybody needs a day off, apparently. Yeah, it is what it is. No one believed that this gentleman, was one to say, oh, hey, something hurts. Let me go to the ER for no reason, just to get a day off. The nurse had told this crew he fairly maintains, a normal daily activity, doesn't really bother anybody, doesn't really talk much. He's been there for a long time, kind of knows the routine. This was something that was weird for him.
So I guess start with the basics. Do your ABCs. How's his pulse feel? That kind of stuff.
So pulse is regular. It's in the 90s.
Okay. And does anybody know of any history with him and use of narcotics or anything like that?
So no drug use, no prior drug use or anything. Wasn't incarcerated for drug abuse or anything like that.
Just murder.
Who knows?
Okay.
Who knows? Typically, that's one thing as a good sidebar is I never ask. I've been in a lot of different prisons in my career. Maximum, medium, low, county.
Yeah.
I couldn't care less. It's
Yeah.
not. It's
It's better not knowing.
I don't know. There's some of them where I'm like, damn, I wonder what got you here. Like, they look like they could kill, like, Chuck Norris.
Right, and they're in for computer fraud.
Yeah, and it's like, whoa. So there have been times where I'm like itching to ask, but you know, you're there as a patient provider. You know,
I mean,
like
just because right off the rip, you know, you want to rule out. Let's be honest. I mean, it's drug use in prison is
rampant,
not unheard of.
Correct.
You know,
might be why you needed those pillows.
No, I'm serious. There's something with like the toilet systems, and if you flush the top and the bottom one at the same time,
they flood
you could,
their
like,
cell, and
flood it and
that's what they do.
Yeah. So
You're ready for maximum security.
seriously,
Right.
I'm so ready.
well, if EMT doesn't work out,
Right.
I guess you have a secondary.
Gang leader. There you go.
So history, as was told to the crew via paperwork provided by the nurse, was there was a cardiac history. There was some minor respiratory history that, you know, the gentleman was on COPD medications every day, was on a simvastatin for high cholesterol, was on a blood pressure. The crew could not recall what one it was, but blood pressure and a water pill or a Lasix pill. So obviously some cardiac stuff, obviously, you know, some respiratory stuff, but nothing like this.
And
ever
overall,
happened.
he's in good health as best as he could be in prison.
Yes. Yep. So ABCs check out. He's got a pulse. He's got clear lung sounds. You don't see any bleeding or anything.
Pupils.
His airways patent. What?
Pupils.
Pupils. So pupils were slightly dilated. They were not, you know, blown or anything like that. They were equal, round, reactive, but slightly dilated.
All right, so next step would be vitals. Let's get the vitals in.
Okay, so like I said, heart rate from the crew was pulse 90s, regular, didn't feel weak or, you know, too strong, bounding or anything like that. Initial blood pressure was 140 systolic over 90. Respiratory rate was in the low 20s, 2022. Unlabored, again, he's really just sitting on the cot, not moving. His hands are in his lap, his feet are outstretched, and that's where he stays.
Blood sugar.
Blood sugar was 150s. 150s.
Okay,
So really nothing to write home about
yeah.
At first glance.
12 lead would be next, and then a neuro exam.
Okay, so when you put him on the 4-lead monitor, you see sinus. Again, heart rate still maintains 90s. Throw him on the 12-lead. You see a 2.5 to 3 millimeter elevation in 2-3 AVF.
Fun times.
And that's it.
Depressions in any of the other
Slight, but nothing to be like, oh man, he's infarcting everywhere.
Does the nurse or any of them have any of his previous EKGs?
No.
Okay,
That's
so
funny.
Talking
You
about
never know.
prison.
I mean, regular doctors' offices don't have
them.
that.
Like, come on.
you never know. Just ask.
It's true. It's a good thing to ask, right? Never can hurt to ask. Someone might laugh at you in the corner, but at least you asked.
All right. And
So at this point, Emily, Kelsey, what's kind of going through your mind? I know you Kelsey, you don't know EKG interpretation and stuff like that.
Yeah, you went
but
right over my head on that one.
That's okay.
All
So
in due time, child.
yes, you'll get there.
this is the
That'll
way.
be when that'll be after resident EMT intern, then you'll be resident paramedic intern. And
it won't be over my head
And we can
anymore.
ask you stuff like that.
Then just resident.
Yes. But then we'd have to change it to resident because I can't get rid of resident.
R squared.
Yeah.
R squared.
There you go. I like it.
I mean, elevations 2-3 ABF sounds like an inferior wall.
I would concur.
That's the nurse part of me.
Yes.
See, not knowing anything about anything that you guys just said, I'm at a loss.
Okay, so
Inferior, superior.
No, I got
right? You
that part.
Inferior wall. We're talking about a part of the heart.
Well, I understood that, but if you would just
You
give
said
him
nothing.
Okay. A little bit less than nothing of what you said.
So right now, what we're talking with this 12 lead that this provider is looking at, they're looking at an inferior wall myocardial infarction. So the bottom portion of their heart is depleted of oxygen. It's infarcting, so the tissue,
not happy.
the tissue is dying due to a heart attack, right? Myocardial infarction equals heart attack.
How's his sats?
Sats are okay.
What did you say his pressure was?
140 over 90s. Initial sat was 88-90. The EMS crew does put them on 2 liters nasal cannula. It comes up above 96%.
Okay.
Oh, that's impressive with the COPD.
Yep.
And you can't get anything about if anything's hurting because he's just going to tell you, yup.
So you ask, right? This provider actually did try and ask all of the OPQRST questions, and you're right. He went, yup.
I like this guy already.
So really, you get bupkis. There's no information. You can't tell whether, the guy hurts. You can't tell whether something's been hurting for 3 hours, 10 minutes.
And we verified this is not his baseline.
This is not his baseline. Normally, the providers reiterate he is talkative, he's coherent, he's A&O times 3,
Okay.
GCS of 15 all the time.
So his last known well was at lunch.
Per the guards. And now it's after dinner, so 5:30, 6 p.m. that evening.
He ate dinner, though?
No, he did not.
When they brought him dinner, was he fine? Or we don't know that.
So they brought him dinner, and nothing was reported.
Okay.
But they did bring him dinner. Nothing was ever eaten from dinner. So now what are we thinking? Gerard, you had said neuros, right?
I was going to say, I still think neuro. I
No,
know
why
that he's having the
why
inferior
are we
wall,
thinking
but
neuro?
Well, and
change in mental status.
Yeah, the mental status, because, we've all had STEMIs, and that doesn't normally change their mental status unless their oxygenation has changed.
Or
to a
their
point where
blood pressures is
or
too
so
low
low they're not
something.
being perfused, right.
Perfusing, but
Right.
they're perfusing while their sats are back up, their blood pressure's
Right.
fine.
There's no reason physically why he should be like this.
I 100% agree with everything
Just
that's
based
said
on
on
what
the
we've
table.
just based on what we've seen so far.
I still think neuro.
Okay, so we're gonna say cardiac for sure, right?
Oh, yeah.
12 leads sometimes lie, but this is in a hospital bed, non-moving. It looks pretty clean, right? We can assume that there is a cardiac issue going on. I agree that neuro doesn't match this cardiac issue, right? Typically, they don't lose mental status. So you start going into neuros, right? The crew did end up doing neuros on this guy. He cannot follow a single command. Does not smile when they ask him to smile. Does not repeat anything other than yup. He is cuffed at this point. So you say, hey, can you lift up your arms? And the EMS crew lifts up the guy's arms. They plummet straight down to his lap again, both together because they're cuffed together.
Squeeze your hands.
Very faintly, but you can get some squeeze. It's a very, very light squeeze, so light that you can't really distinguish if left is weak or if right is weak. They're both weak.
Same with the lower.
The lower doesn't move.
Any facial droop when he says his yup.
So EMS crew did actually notice some left-sided facial droop.
What, like whereabouts though?
Right in the lip mouth area.
Okay.
So it wasn't like a palsy or anything like that where they would think, oh, okay, maybe this is a pre-existing neurological.
Did he walk to the infirmary?
No, he was brought to the infirmary via the guards.
Is he on a blood thinner?
No.
He will be soon.
So this is an odd case, right? Like this was presented to me and I'm just scratching my head going, what the crap?
So if we were to give him like a fast ED.
I'd have to honestly look at what that.
I don't think
like-
it would be a high score on a fast ED.
Yeah, that's what I'm thinking.
I
It's
always-
a large vessel.
That's
This
what I'm
doesn't
thinking.
really sound like a large vessel.
Okay.
Here, wait.
I always have.
Pulling up the app.
Yeah, I was
I
gonna do the same
always
thing.
have to look at the app.
Oh yeah, I would.
Can't drink
I
that way.
cannot remember.
You think I pulled that out of my ass? Hell no.
But that's an interesting point too, because in EMS they drill the Cincinnati.
Yeah.
That is so non-specific. There's so many infarcts that happen in your brain that the Cincinnati will not pick up.
Correct. I mean, Cincinnati can work on telling you, yeah, someone screwed up, and then you check their blood sugar and it's 12.
Well,
And it's like, oh, look,
Right.
That's why
Cincinnati
they screwed up.
failed.
the Cincinnati's going to tell you like, hey, they're having an issue, and you're going to be like, no shit.
Right.
Right.
I can see that from the door.
Yep.
All right, let's try this out. No blood thinners, you said.
Negative.
How old?
Upper 60s.
We don't have a time for when it started.
Negative.
We don't have the last known well was lunch.
Last known well was,
So it's like
I would say
greater than
about
4 hours?
6 hours.
Yeah.
If I had to make an educated guess based on the story,
Facial weakness.
yes.
Yep.
Left-sided.
Arm weakness.
I mean-
mild,
If he's
moderate,
not,
or severe.
if he's not moving them.
If he's and the other thing that really pointed out to me when this provider was telling me the story was that typically, okay, you got your arms cuffed, right? They're cuffed together at the wrists. You bring both of them up. If one of them is weak, that other one should be able to overcome because they're connected.
Right.
So you just
These
have-
went both down. There was no report on whether they went down separate, like one stayed a little higher than the other, but you can assume that there is weakness somewhere,
I mean, this
left
guy
or
should
right.
be able to hold his arm up.
He should be able
So that's
to.
a significant finding.
Right.
Yeah.
I would think that would be a significant finding if I'm in that position.
Any gaze deviation?
No. But pupils are dilated.
Oh, he actually scored a 5 on our fast ED.
Okay. So for the people in other areas that might not use fast ED, what is a 5?
So a 5 is a large vessel occlusion probability is 60 to 85%.
Okay, so
And that's all our fast ED is recognizing is the large vessel occlusion.
right. So we're thinking now with that, okay, possibly this guy has a really, really bad stroke going on in his head. Maybe, maybe not. What do we think here at the table?
We also have a STEMI in hand.
And
I
we
mean, I was
also
gonna
have
say,
a STEMI at hand.
Yes, I think that that's true, but I think that the cardiac issue is going to get him first.
Okay.
Of course.
Okay.
I mean,
So
there's nothing that we can do pre-hospitally for a stroke, really.
not in this state. There's
Welcome to New York.
welcome to New York. No, there really isn't anything for us to do as EMTs and paramedics other than blood pressures, oxygen, and airway.
Check his sugar, manage it.
Right.
Right.
You know, and that's really it. Now we can do stuff for an infarct. Okay. So moving on.
But the stuff we do for the infarct might have an adverse effect.
Hold on, we're not there yet. Okay, so we get this guy outside on the stretcher. We are now moving towards the level 1 trauma center, heart center, stroke center, right? All combined. We're going to the appropriate facility,
Okay.
right? We're not going to the, TPA place down the street. Going to the right place. I like where you're going, okay?
Okay.
This provider now is in a position where they are looking at a gentleman who's having a STEMI, who's having a significant cardiac event, right? 3 millimeters of elevation is significant. And possibly a large vessel occlusion CVA. As you brought up, you want to treat the MI. In New York, we're going to treat it with aspirin. And we're going to treat it with nitro.
Yeah.
But what if this is a hemorrhagic stroke and not an occlusive stroke?
And then you just killed him faster.
And now you're making one problem
What if you
worse,
don't treat it
fixing
with
the other
nitro?
one. What do you mean? What if I don't fix
What if you hold the nitro?
But if you're still giving aspirin, it's still an anticoagulant. And if it's a hemorrhagic
It's
stroke,
an antiplatelet. And I would still give
Antiplatelet.
the aspirin.
Okay.
I
Why?
would still give the aspirin. Because
I'm just curious as to why.
I
This
just
is
think-
this is the table discussion that I wanted to have. So really, for the rest of the call, I'll let you guys know what was told to me.
Almost the exact opposite. I would give the nitro, and maybe
I wouldn't give the nitro
some
if you don't know.
fluid.
I don't. So I think clinically, presentation-wise, to me, it doesn't sound like a hemorrhage. You can pretty much have a good guess if it's a hemorrhagic or an ischemic.
Okay.
It wasn't like super sudden. If the last known well was lunch.
Yep.
There's no seizure history. Like, yes, there's a change in mentation. Pupils are equal. It doesn't sound hemorrhagic to me. I would not hold the aspirin. I would give the aspirin. I would hold the nitro.
Why would you hold the nitro?
Just in case it's the hemorrhagic stroke.
okay.
You can't take it off the table without a scan.
So I'm curious as to what is the nitro going to do in your mind to the hemorrhagic stroke?
Make it worse. Make it
How
so
so?
bad that you won't be able to fix it.
How so though? Like that's what I'm curious
By
about.
dilating. If you're going to dilate everything's going to bleed out of your brain. Then you're going to start to have herniation.
Okay.
That's what my concern is.
It'll increase the pressure faster
Absolutely.
than if you
Way
just
faster.
let the current bleed.
So
bleed.
if you give an
Okay.
antiplatelet, think of it as like a trickling sink.
Right.
If you give a nitro, think
We're
of it
gonna
as
open the faucet.
opening
Yeah.
the faucet.
I see what you're saying.
Okay.
Yeah, that does make sense. Yep.
That is not how I would have thought. Because I was in the boat of hearing this story. I was in the boat of give the nitro, because the nitro's
hold
not
the
going,
aspirin.
and hold the aspirin. But then I started thinking, okay, is there signs of hemorrhagic stroke here? Not really. This provider chose to give both. He chose, okay, there's not enough signs of trauma here, that it could be a spontaneous bleed, it could be a bleed because of trauma. So they were thinking ischemic. So they gave the 4 aspirin. This guy couldn't chew aspirin. So they said that they just tucked it in his cheek and let it sit there. Maybe it went in 45 minutes, but it went in eventually, right? They ended up giving the aspirin for the cardiac issue. And they rolled the dice that it was not going to make worse the CVA issue. They also gave the nitro, even though, that provider, I had no idea that nitro does that in CVAs. So that's an interesting teaching point around the table for me today. How many providers know that aren't, Emily nurse should be a paramedic? Other than my wife would know that. But
I was gonna say I can think of at least one other that lives.
So
With
what,
you.
what would your so let's say we did think of that, and let's say his BP was a little higher than it is. What would your thoughts be on using something like morphine to perhaps
So
take
that's
some
what I
of
was
that BP
actually
down?
gonna suggest. Was give the
Yeah.
give the aspirin, give morphine,
Get that BP down a little bit. Yeah.
and decrease that oxygen demand on the
Right.
heart.
Yeah.
You have an infarcted
especially,
heart.
the other thing too is here's an inferior wall MI, and we're sitting here going, okay, the nitro's gonna help alleviate some oxygenation issues, but it's also gonna possibly tank pressure and preload, which you don't want to do in an
Yeah.
inferior
Inferior
wall.
wall, yeah.
This guy's maintaining
Right.
most likely because of the stroke, not so much because he's got an infarcting heart, right? Inferior walls typically are
Drop blood
hypotensive,
pressures,
Right.
right? You lose all your preload because the workhorse of the heart is capuzzo. So really, do you want to give nitro at all at that point
So
in time?
that was yes.
Right? Thinking about it even further.
Yeah.
I like the morphine. I like, I don't think this provider had any issues giving any type of medications. There weren't any known allergies or anything. Some places have enough morphine. Some places would give fentanyl in that situation just to not lose the blood pressure.
Right. To maintain that pressure.
140 is going to perfuse the noodle. Do you want to drop that and then lose the perfusion in the brain. That would be another thing to think about.
And that's really the only thing you can do for a stroke pre-hospital in New York State is make sure that you keep those maps up to keep perfusing all of the brain you can.
Right. This is an interesting one. So, like, we have multiple different ways of attacking one call, right? And this is why I wanted to tie this in with the pull the trigger conversation that we've already had. Is like, is this the type of patient where you sit on everything and just drive? Like, they're a half an hour drive from point A to big hospital. Do you just sit there and go, I'm not fucking around with this. This is above my head. Let the, cardiologists and the neurologists mess with this one.
No, knowing me, probably not. Yeah, I know.
It's really tough.
Yeah, it is a tough choice.
Well, I mean, hindsight 2020, we're all sitting at a table, but in that moment, without having thought of what you were talking about, I probably would have went down the same road. In my mind, I probably would have withheld the aspirin just because I'm thinking the way you were thinking, and I would have went the nitro route and whatever else, but some fluid and treated the STEMI.
But that's also what we're drilled into pre-hospital is like, STEMI, treat it with this. Mona B. How many times have we heard that?
Oh, and that's, it's a funny thing because we're always also taught time is brain and time is muscle.
Tissue, right.
Right? So here you are sitting in two distinct time-sensitive things that if you don't treat one, it could make the other one worse. Or if you treat the other one, it could make the other one worse.
I mean, another way you can look at it, too, is to help guide you in what you're going to treat or, if you're going to sit on your hands for it, would be, is it really a time issue now for the stroke? We're well outside that 4-hour window.
That is true.
I mean, I'm not saying, don't get them there as soon as possible, but, I mean, it's, if we were still...
What's the 4-hour window? For what?
For stroke.
For strokes.
For what treatment?
TPA.
Is it the 4-hour? No, 4 hours is not TPA.
That's what we're taught.
That's what we're taught.
Oh, really? Okay.
I thought it was 6.
It's TPA works in 6.
It's actually 3.5 hours.
So we actually have it. We've stretched it to 9. That's why I wasn't sure if you're talking about like the Mercy procedure. Or
I mean, heck, fucking Albany Med has a 24-hour window for occlusions because they can go in with the grabber and pluck it out.
The grabber, thing, like the corkscrew thing.
They just go in and grab it.
4 hours was.
I was like, I thought it was 6.
Yeah, they said for fibrinolytics.
It is 6.
For fibrinolytics, in fact, I literally just did the CME 2 days ago. 3.5 hour window.
I just gave TPA last night for 9 hours outside of a last normal.
Wow.
Mm-hmm.
That's why I don't.
Education standards.
Yeah,
man.
those education standards lagging behind everything else.
In the ER, in our ER, it's 6 hours. Like it's in our policy, it's 6 hours. The docs can stretch it to 9, but that's why I didn't know.
Okay, yeah.
Never mind, carry on.
Like I said,
stick with 4.
All I know is, I think even in our protocols it even mentions the 4 hour.
Mm-hmm.
Yeah.
Yep.
So, well, way to stay on top of the ball there in New York State.
I mean, it is New York State. So now that we've talked ALS for a while, I want to talk to Kelsey here because.
So I have a question.
She's got a question, then I have a question. So yes, ask your question.
So, even if you can fix his heart, wouldn't his brain be too damaged at this point for him to ever maintain baseline?
All depends.
What do you mean by ever maintain baseline?
Like, a lot of people who have strokes never return to their normalcy. And we're talking about a person who's in a prison, so having to have extra help while you're in a prison isn't going to work out well for him anyways. So if you're trying to fix his heart and you fix his heart but make the stroke worse, wouldn't at the end of it, even if you can't bring him back to a normal neuro standpoint, he's kind of screwed?
So most people that have deficits from strokes either have a clot that is so far out, like 12, 24, 48 hours with not knowing, or they have a bleed.
Okay.
The fact that he's been seen within the last 6, 8, 10 hours, normal, and we don't suspect it's a bleed, gives him a good chance of recovery.
Okay.
Or if he does have deficits,
Yeah.
maybe not as bad as you're thinking.
Right, yeah. He
Okay.
may not ever be normal again,
Right.
but he might still be
He
functional.
might still be
and-
functioning.
Okay.
At least functioning enough to live in
Right.
prison.
Live in
Right.
prison.
Yeah. He can still fight off the gang rape.
Maybe. I mean, you never know. He's 68. He's been there a while. He might be the gang raper.
Yeah, that is true.
You know, you don't know.
Why you don't ask?
So I'm
Wait,
curious
you
as
just used a singular with a plural. Can you singularly gang rape somebody?
he might be the leader. I don't know.
Oh, there's that freaking college English education there. Yeah.
I went to art school.
right.
There was no
All
English.
right. All right, so back to the ambulams.
Oh, I didn't have to edit, but 15 minutes out of the first section when we all yapped for 15 minutes
Right.
out of the last one.
Oh, no.
I'm going to have to edit like hard this one.
Somebody brought up prison.
Sorry. How do you talk about prison without gang rape?
Or dropping the soap,
Right?
you know?
We didn't talk about dropping the soap.
Nope.
We hit just about every cliche, though. You know, Pruno, fresh pillows and socks, shot callers, shivs,
Yeah.
The toilet flushing system.
toilet flooding, flooding the cell. Yeah.
Currency.
Yeah. Yes, yeah.
Nope. Yeah.
All right. Sorry about that. It's always me.
So, Kelsey, I'm curious from a BLS standpoint, right? You as the intern here, how are you going to tackle this call? Knowing, okay, you are, as Gerard and I would say, there's a cloud over Omaha, so you can't get a helicopter, and you're way out in the sticks of Gilboa, and if anyone knows where that town is, you live there. So, awesome. So you're not getting any ALS help at that point anytime soon. How are you going to tackle this call?
So the only thing that we can do at a BLS level for an MI would be aspirin unless they're already prescribed nitro, which this guy wasn't. But I never would have even wanted to do that because in my mind, I wouldn't have been able to tell the difference between an ischemic or hemorrhagic stroke because the only thing that I've been taught in class is that if it comes on with like a thunderclap headache, that it's hemorrhagic. And that's the only thing that I would know to be able to tell the difference. And when he's sitting there going, yep, that doesn't help me know how it came on. So I don't even know if I was given the aspirin.
You could literally sit there and go, did this come on like a thunderclap headache? Yep.
Yeah, but then if I go, did it come
Patient
on
says
slowly?
yes.
And he
Patient
goes,
says yes.
Yep.
So, but then you're saying you would have held the aspirin.
Yeah, I
So
would have.
That's fair.
Mm-hmm.
Because
disagree
I
with that,
never
Kels.
would have been able to tell from what the knowledge I have the difference.
And technically, she never would have been able to know if he was having
And
a
I
STEMI.
never would
Right.
have even been able to know that.
You wouldn't have even known if he had chest pain or anything.
No.
Yeah.
I
Just-
literally
and-
would have
and
just
that
been
was-
able to look at him and been like, ooh, we better
But
drive
if
fast.
let's
you
go.
have a patient that's all they're saying is, yep, what are you thinking?
I'm thinking neuro. I never would have even thought MI.
Well, and
And then I'm
that,
definitely not giving aspirin because I have no reason to.
and I'll
Right.
tell you, the really interesting thing about this is you and I ran this scenario in many EMT classes. And I lay it in as this is, you walk into a prison, the nurse gives you a 12 lead and says, here, he's having a STEMI. That's the information that you get along with when you ask questions. You technically don't really know or, are taught what a STEMI is in EMT class. You're taught what an MI is, but
Right.
not like, here's visible
oh
proof.
yeah, if somebody handed me that, I'd be like,
Exactly.
I know
And that's
the
squiggly on paper.
You're
basics.
holding it upside down. There you go.
Well, and that's the really interesting part because most of the EMTs looked at it, said, okay, and then
yep.
put it on the floor.
I
And
would
they
at least stuck it in my
they
pocket.
completely forget about it. And then they try and sit there and go, okay, she's telling me, this nurse is telling me that it's cardiac. I have to fit these symptoms into cardiac, which
Square
they
hole, round
don't.
peg.
They don't.
Right.
Which they don't, right?
Square hole, round peg.
And that's
Right,
exactly
other way.
it. They never search for why is this person altered, right? They're altered. I mean, eventually, at the end of this call, this gentleman did have a gaze upwards and to the left, did have listing to the left, and I mean, that's 25 minutes after first contact with EMS.
So originally, was it like lights on, no one home? Like he wasn't even looking anywhere?
Nope. He looked literally straight ahead.
Lights on, no one home.
Lights on, no one home. Yeah.
Because if you had given me just that, I would have thought after I'd done a glucose neuro.
And that's exactly it.
And if they'd given me that strip of paper, I would have been, cool, stick it in my pocket, give it to the next person
Okay,
who knows more than I
Right.
do.
I mean, but the other thing is, too, is the fact that they're having an MI that we can prove on a 12 lead clues into me, like, that's more indicative that it's an ischemic stroke.
Yes.
If you're having clotting issues in one part of your body,
Right, you're gonna have it in the
that you're
other.
going to have it in
Yeah.
others. Is
And
so
that was one of the main. I'm so glad you brought it up. I was waiting for someone to bring it
I was
up.
going to bring it up earlier, it just wasn't.
That was one of the
holding it.
main deciding factors in this paramedic's thought process of it's not a hemorrhagic stroke, it's an ischemic
Because
stroke,
if you're
right?
clotting somewhere, why
It's
would you be
probably gonna
bleeding
go-
somewhere
If
else?
you have a clot that traveled to your heart or started in your heart, why is it that far-fetched that it went to your brain?
And
It's
that-
not.
It's not.
Right.
Not
It's
at all.
not at all.
Very likely.
Yep. You know, he could have popped off 8 clots and
Exactly.
who knows where the heck they are.
Yeah.
You know, there's a DVT, there's
Now he's got a
there's a
PE,
PE
right.
somewhere, you know, down the road. They're just making their way, and the
Getting
MI
stuck somewhere.
the MI might have started first, or maybe
Maybe not.
not.
Yeah.
Hard saying, not knowing at that point.
Okay, I have another question. So if you had a bunch of clots that caused an MI, would those clots get worse or better? Because you wouldn't be pumping out as much blood.
Depends on where they are.
Okay.
And
I'll
I would
accept
have,
it.
and
Well,
I would
why
have
aren't
to
you-
say,
but why aren't you pumping out as much blood?
Because your heart is hurt, so it's not pumping as much.
So where's that clot?
its feelings are hurt or it's hurt.
It's hurt.
Okay.
Not its feelings. Does heart have feelings?
Everyone seems to think they do. Gerard, you really want to say something?
Come on, Gerard.
No. I'm going to cut down on the editing time.
Okay. Thank you.
Yeah.
So carry on.
I don't even know what I was saying now.
Heart hurt.
So you were asking
Oh.
if the clots would
So would they
become
end up
more
getting like,
severe.
yeah, like would they just get stuck more in the heart, or would they go like,
Would they continue to build
yeah, it's basically,
after being lodged?
I want the aspirin.
that makes sense. But if I'm thinking neuro and don't know they're having an MI, I'm not giving them aspirin.
And like we were talking about with, if the blood is the right way, you're now introducing more turbulence into the system. More turbulence means you're going to build more
Build
clots.
More of that clot.
Yeah.
Yep.
No. And I think we all could talk in circles around this call all day long. I think just overall, it is a choice, that comes down to what we were talking about. Has anyone seen this before to sit there and go, hey, I've had experience here. I've done this before.
Right.
This is what it was. This is kind of what I did, right? There's a lot of judgment decisions going on in this one where you're like, okay, here's my protocol. Does it fit? Here's my symptoms. Do they fit? I can treat down one way. I can treat down another. I kind of just have to gamble on one way or the other. I honestly don't think that either way is wrong, right? I don't think giving the aspirin and possibly making the CVA worse to treat the MI was wrong. I also don't think withholding the aspirin
It's wrong.
to make sure that the CVA doesn't get worse
Right.
is wrong. I don't think either one is wrong. And that's where I brought up sitting on your hands.
Yeah.
In this situation, could be a viable option.
So what would you have done if you're an hour and a half out because you're in Gilboa and now you got nowhere to be?
I call my wife.
No. No.
No self.
Oh, that's right. I
Cloud
can't,
over
right?
Omaha.
Cloud over Omaha.
Self-service.
God damn it, honey.
Right. You're flying.
I still think that I would probably do
Because I feel like sit on it's no longer an option.
sitting on it is no longer an option if you're 90 minutes from, that kind of hospital.
There's also another option that none of us have really touched on right now because we're all
Call a doctor.
There it is.
I thought it earlier, but I didn't want to sound stupid
Because we're all
saying
gods.
it.
And we're gonna figure this problem out.
I was
would
actually
call a
going to
doc.
ask, did they call a doc?
In this situation, I think before I did anything, me personally, I probably would have picked up the
I
phone.
think I would have
Okay,
What
so-
do they want me to treat?
Yeah,
Okay,
what would
so
you like me
what
to
do
do, Doc?
right? So what are you gonna ask? Like, just literally, here's what I got.
I just
What
sent
do
you
you?
the 12 lead. Here's the patient presentation. This is what I've got. What would you like me to do?
So you completely defer.
Completely defer.
So what do you go? Okay,
Take myself
Their
out of the
license.
equation.
here's the patient presentation. Do you even mention, hey doc, here I think he's having,
I would
my
mention
fast
that.
ED 5.
Oh yeah, no. I'm gonna give him all the information.
Absolutely.
Everything I've got, I'm gonna make sure because I need to paint him a good picture.
A really damn good picture in this situation.
Yeah, I can't just say, hey doc, I just sent you 12 lead. What do you want me to do, man? No.
I'd be giving him my best educated guess.
No, I'm gonna give him paint him the complete picture. You know, when he was last seen normal, what he looks like now, how he's been in my presence. You know, where we're at, the weakness with the arms, all that stuff, the fast ED score, and there's the 12 lead. Mm-hmm. I have a confirmed STEMI. I'll probably take another one, if not 3.
Yep.
Just to make sure.
Or 5.
Yeah, right. Just to make sure that it wasn't just some hiccup.
Wasn't a fluke.
So. Yeah, paint him the complete picture or her the complete picture, and then I would defer. What would you like me to do?
I think that is a brilliant thought process. This paramedic chose not to do that.
Because
And
we have
roll
capes.
the dice. Roll the dice, huh?
Because we have capes.
We do have capes.
They blow in
Especially
the wind.
and think of this now too. This was a brand new paramedic.
Mm.
So does that have anything
What a call! Wow.
right? Like literally
Poor guy or girl.
literally
Right.
2 weeks after being set free by the state. Here you go.
Joke's on you.
Have fun. You're a brandy nandy new super paramedic.
Yeah, it was like my third week out with the guy with the Levofed, and I'm like, I think I got to use Levofed. How do you do that again? Shit.
And I'm sure that this was one of those like, I'd rather bang my head on the wall 100 times
Yeah.
than have to deal with this.
Right.
This, in my book, earned a Coca-Cola and some Skittles afterwards.
Absolutely.
If I was that paramedic, Coca-Cola, some Skittles, debrief yourself.
Yeah.
Brilliant. But how much does that factor in?
Coca-Cola and
I mean,
Skittles?
no, just being new.
No experience, right?
There is zero experience behind this paramedic other than being an EMT.
Yeah.
It's probably his first
Never-
MI and first stroke all tied into one.
Probably. I can't tell you for sure, but
No,
probably.
And I've been there where, either during QA/QI process or just shooting the shit after a call, and someone saying, well, why didn't you call a doc about that? And there have been many times where I've been like, yeah, I probably should have, but in my mind I could handle it, and I knew what to do, and I was confident in what I was doing. There may have been more than one way to handle it. I chose my way.
Hindsight's 20/20.
And it's easy to be,
Monday
Caught
morning
up in it.
quarterback.
And
right. It's easy
Yeah.
to sit there and be like, man,
Most important thing though is if you do get up in that situation and you do, you're talking with your buddies after a call or you get that QA, take that step back and be honest with yourself and really listen to what the other people have to say, because hey, you may have been right, but maybe there was a more right way to do it.
And
kind of sound like
learn
National
from
Registry.
it.
and and to build on that, I
New York
think
State exams.
I really think you touched on a great point in that trust the people around you.
Mm-hmm.
This paramedic is standing there by themselves, right? Thinking that they have to figure everything out. Bounce some ideas off your EMTs.
Or the nurse.
Or the nurse, right? Before you leave there.
Or your nurse EMT.
Or, right. Make sure Emily's
that you
there.
have on speed dial.
I think calling a doc is a fabulous idea. Make sure you call the right doc, like the one where you're going, not some other hospital,
please.
because that shit happens all the time.
Please.
It's like, why are you calling a hospital that you're not even going to?
I actually worked somewhere where that was encouraged because they knew
Drives
which
me crazy.
doctors,
They knew which
would,
doctors
give
would give what they want.
you wanted.
That drives
yeah.
me
I
nuts.
don't
Yeah.
like that. I
It,
would,
please
it
don't do that.
never
I wouldn't
makes
play
sense.
ball. Sorry.
I wouldn't play that. I wouldn't play that game. Not even. Nope.
Yeah, no.
Not happening.
To me, that's the equivalent of doctor shopping as a patient. No. Not
Yes.
Yes.
Yep. I agree.
Exactly.
Yeah. Anything else to add before we wrap it up?
I have a question. What happened to the guy? Do you know?
He lived.
Did he go to the cath lab?
Yeah, where
They immediately went to
CAT scan.
CAT scan.
Right, I figured that would be first, yeah.
They immediately went to CAT scan. The guy did have a very large ischemic stroke to the right hemisphere. Very, very large, from what I've been told. And like golf ball size. And no prior history, like I said, just the cardiac history and some other stuff. So it wasn't like, oh, hey, this guy's been having TIAs for a week and a half, and boom, now he's got the big one. It's completely sudden. But yeah, other than that, the crew doesn't know.
So then, yeah, so
And
then, I mean,
didn't pass along to me.
in the hindsight, then your treatment of the STEMI as normal probably
Would have been fine.
did some good, or at least held off the inevitable for him.
I mean, looking back, yeah, I think the provider, choosing to give the aspirin,
Not knowing that was
not
what he was
knowing,
helping.
right.
Yeah.
And again, I think that provider really rolled the dice
Yeah.
in, well, I'm going to fix something, or I'm going to intubate this guy really soon. I mean, really, that's what it came down to,
I
right?
mean, but the nitro didn't hurt either.
And
Yeah, that's what I was getting at.
Right.
Because he
The
treated
nitro
with
nor
both,
the
yeah.
aspirin, right?
you know,
Yeah.
so it
Well done.
I guess so. Well done. It's just, like I said, to wrap yourself in this call and then looking at it after and talking about it, it's like, damn, I don't want to make that decision as a provider. I'd love to be blissfully ignorant like Kelsey and just being like, I see neuro, I'm going to treat
We're
it as
driving.
neuro.
We're going
Diesel
fast.
bolus, let's go. Like, I'd love to be able to do that.
Oh, those were the days.
Those were the
There's a few
days.
that still do it. Come on.
Yes.
Yes,
but-
there are.
Yes. Anything else to add before we end? Everyone's sufficient. We've beaten this dead horse enough. I think. Yep. Okay.
Yep.
I think consensus agrees. So guys, till next time. Yup. You will be thinking about yup.
Wasn't that a Hanson song?
No, that's bop.
Different kind of stroke.
Yup. You could totally do that. That'd be funny. So, guys, next time we will see you, it'll be December 1st with another call review and or discussion. And then from there on, we will see you every 2 weeks after that. So on the 1st and 15th of every month. So till next time,
Happy
stay
Turkey
strong.
Day.
All right.
Happy Turkey Day. There you go.
I was going to say donuts, but there it is.
Donuts.
Thank you for taking time to listen to the Medic Materials Podcast. If you got anything out of today's episode, be sure to follow the podcast. If you want to be a part of our daily EMS discussions, join the Medic Materials EMS Education Group on Facebook. And be sure to watch our weekly instructional videos on the Medic Materials YouTube channel.